show of hands. How many people believe that the opioid epidemic is actually something that we've had in this country for the last 100 years or more? Show of hands. Very good. In point of fact, the opioid epidemic has a very long and storied history. We clearly have paid a great deal of attention to it in the recent past, and I believe that part of that has to do with the fact that we've got now a great ability on our smartphones and in the lay press to have access to an enormous amount of data that was previously not available to us. These are my disclosures. I don't have anything to disclose in terms of a conflict of interest. I tend to ramble, so if you see me doing that, you can wave your hands frantically in the back of the room to keep me back on track. I'm the chairman of the anesthesiology program at Advocate Illinois Masonic Medical Center, and I'm also a professor of clinical surgery and clinical anesthesiology here at the University of Illinois College of Medicine. So we have some learning objectives. I want to talk about the current opioid crisis and place this into a historical perspective. I also want to talk a little bit about the impact of the pharmaceutical industry in the evolution of the most recent iteration of this crisis, and about the future directions of the opioid crisis in this country and what we can do about it. So those of you who raised your hand in response to the fact that we've had a long-standing opioid epidemic, you can pat yourselves on the back. We've had a history that dates back at least to the American Civil War, if not earlier. So this was a graphic taken out of a peer-reviewed article, and of course there's a glaring mistake. Opium was not synthesized in 1804, but actually morphine was extracted from opium in a small pharmaceutical basement out in Austria, out by Germany. And I'll tell you some of the history. In 1853, we had the invention of the hollow syringe and needle in Glasgow, Scotland. So the first thing we did was we had morphine extracted in 1804. Before that, all we had was laudanum, which was a viscous preparation of opium, which was very useful in households to reduce sleep, to reduce colic, and to help individuals suffering from maladies, many of which we all suffer from on a regular basis. Then Frederick Sir Turner, who was a pharmacy assistant, a young 21-year-old pharmacy assistant in Austria, actually was tinkering around in his laboratory in the basement of the pharmacy and was able to extract morphine from opium. This was an incredible advancement in the annals of modern medical history. And so, in conjunction with the fact that we now had morphine instead of just having opium, or exclusively having opium, Alexander Wood in Glasgow was able to actually create the first hollow needle and syringe. And this was done in 1853. So by 1853, we had actually morphine, and we had the ability to inject morphine. So what does that correspond to? Well, in 1853 was immediately before the American Civil War of 1861 to 1865. And actually, those of you who know history know that soldier's disease refers to the 400,000 or so Americans who were addicted to morphine during the time of the American Civil War. 400,000 Americans. Now, how do we know those statistics? Well, we really don't. Right? We didn't have mass media. People weren't walking around with cell phones and smartphones. We had newspapers, which took a week to print. There was no television, there was no radio, but we knew that there was a huge number of individuals who were addicted to morphine. So the Civil War was catastrophic in terms of deaths, 620,000 deaths of Americans. Put that into the world perspective of the number of individuals we've lost from all the other wars combined. It doesn't even come close. 400,000 addicts, we called it soldier's disease, but also the Civil War was unique because Silas Weir Mitchell defined and described complex regional pain syndrome. Of course, he called it causalgia. Post-traumatic stress disorder was also described for the very first time during the Civil War. And most of the morphine use came at the conclusion of the American Civil War, not actually during it. Soldier's disease, or Army's disease, was actually that syndrome which corresponded to this massive amount of individuals who were addicted to the use of morphine, not orally, but actually by the use of the hollow syringe and needle. Now, interestingly enough, because of the addictive properties of morphine being widely respected and recognized, back to London, we had a great thinker and physician, C.R. Alderwright, who said, you know what, I'm going to try to create a substance which is less addictive than morphine, and he was able to create diacetyl morphine, also known as heroin. So he did so with good intentions. He believed that heroin would be a less egregious compound to be using for managing pain and colic and sleep disturbances and so forth, and diarrhea, than was morphine. And obviously he was notably wrong in his assumptions. And morphine was actually the first product which was manufactured by the Bayer Company. You've all known about Bayer aspirin. And for a 15-year period, Bayer made billions of dollars, not from selling aspirin or creating aspirin, but actually from the manufacturing and selling of heroin and distributing heroin worldwide until about 1913. And they suddenly ceased and desist the sale and production of heroin in correspondence to the Harrison Act, which was in 1914. We'll talk about that momentarily. And so morphine has a long and storied history. It was actually used to cure other addictions. The great Sigmund Freud from Austria, from Vienna, who never knew William Stewart Halsted. William Stewart Halsted is the father of modern surgery. He created the surgical program at Johns Hopkins University. In fact, he created Johns Hopkins University in Baltimore. And he was obviously one of the world's most notorious cocaine addicts. And in conjunction with that, he sought treatment for his cocaine addiction and was treated with morphine because at that time, Freud and others believed that morphine was a less dangerous or toxic compound than was cocaine. The first pain clinic was started in Seattle, Washington, or the first multidisciplinary pain clinic by the great John J. Bonica. I had the privilege of meeting Bonica. I had the privilege of actually anesthetizing his wife, Emma, in New York City, where Stephen Opsbaum, an ophthalmological surgeon, fixed a botched surgery that she'd undergone in Seattle, Washington. And Bonica was the forefather of the modern pain management center. So the first drug laws were actually created in the city of San Francisco in 1875. If you go back in history, you can recognize that San Francisco was a city filled with squalor, drugs, prostitution, homelessness, human waste littering the streets. In fact, it sounds like San Francisco today. There's been no change. The first drug laws were actually created due to the influx of Chinese immigrants that came into the city of San Francisco for two purposes. For the gold rush of 1849, you've heard of the San Francisco 49ers, right? And to build the Transcontinental Railroad. But after the railroad was completed and after there was no more gold to look for, this huge population of Chinese stayed and created opium dens. And so the first drug laws in this country were created actually in reference to this group of individuals with no jobs, with no employment except to sell opium and to basically to promote prostitution and gambling and so forth. And then in 1900, there was an editorial in the Journal of the American Medical Association which talked about this new phenomenon which was very, very prevalent among Southern black individuals, which was sniffing cocaine. So the first drug laws were actually created and aimed at two minority populations, the Chinese and then the African Americans in this country. We had the first pure drug, Food and Drugs Act, which required labeling of all these chemicals in 1906, but it was left to Francis Burton Harrison, who was a Democratic senator from the state of New York, to create the Harrison Act. And this actually looks something familiar to those of us who are following the whole prospect of legalizing marijuana in contemporaneous times. So the Harrison Act was a federal law. It was created to regulate and tax the production, the importation, and the distribution of opium and coca products. And in fact, in 1906, you could buy opium or morphine or heroin through the Sears Roebuck catalog. And this is actually an excerpt from the Sears Roebuck catalog. For a couple of dollars, or for even pennies on the dollar, you could buy cocaine, you could buy opium, you could buy marijuana, and you could buy hollow syringes to administer these to yourself without a oversight or a physician's prescription. Now, Francis Burton Harrison, a very interesting character, married 5 times, raised in the Philippines, and he was the forefather, the thought producer of the Harrison Act in 1914. Interestingly, and I found it to be interesting, Harrison died on the very same day that I was born, in the very same hospital where I was born. I didn't know him, though. We never met. But Harrison died at the very same hospital in New Jersey where I was born on that day. I thought that was interesting. Now, how did we get to the crisis? Well, there were 2 articles which were carelessly published in peer-reviewed journals. One in 1980 in the New England Journal of Medicine. It was actually a letter by Porter and Jick. The other was in 1986 by Russell Portnoy and Kathleen Foley, which was published in the journal Pain. And I want to talk about them for a few moments because these formed part of the foundation for the modern opioid crisis, or the opioid epidemic. And the reason why they formed the foundation was the pharmaceutical industry took this information and ran with it and started to promote opioids across the board in primary care offices across this country. So the letter from Porter and Jick basically looked at almost 40,000 hospitalized patients, 11,000 of whom had received opioids, and they found only 4 legitimized cases of addiction associated with this use of opioids. And they stated that the development of addiction is rare in medical patients who don't have a prior history of addiction. Then Russell Portnoy, who's really been basically considered to be one of the evil geniuses behind the opioid epidemic, respectfully, working in New York City, looked at 38 total patients. And along with Kathleen Foley said that the use of opioids in patients with intractable, non-malignant pain and no history of drug abuse was a good idea. Well, what happened? And of course, JACO basically tries to remove all complicity with all of this process, but they actually created a primer, which was with the help of Purdue Pharma, which was distributed to all physicians across the country. And Portnoy, of course, had great conflicts of interest back in the 1980s. If he conducted his business and wrote that kind of information in contemporary times, he likely would have been the subject of intense scrutiny and possibly even jail time, because he received hundreds of thousands of dollars from the Yes, he is. A pharmaceutical industry, but likely at the end of his career. And so, basically, this primer, which was published by the Joint Commission, and they try to deny it and remove all culpability from the opioid epidemic, but the primer for primary care physicians was created based upon these letters of Porter and Jick and this very small study of Portnoy and Foley. Vittorio Ventafrida, I mentioned him just in passing. He was a classical figure in pain management. He helped create the World Health Organization stepladder approach for managing pain, but he also had a pedigree that basically crisscrosses with my own. He did his anesthesiology residency here in Chicago at the University of Illinois College of Medicine before returning to his homeland in Italy. And along with John Bonica, he was instrumental in creating the World Health Organization and many, many other things. And so the stepladder approach for managing pain actually categorizes patients, those with mild pain, 1 to 3 over 10, moderate pain, 4 to 7 over 10, and severe pain, 8 to 10 over 10, and states that for individuals with mild or moderate pain, we ought to be using either no opioids or short course of opioids. And it's only for the most severe levels of pain that we should progress to extended release or more potent opioid medications. So what do we have now? We have 150 years of an opioid epidemic, but now we have much greater means of gathering and collating and assimilating statistics. We have prescription drug monitoring programs. We have access to huge databases that were previously unavailable to us. In 2007, in recognition of this misbranding of OxyContin, Purdue Pharma, 3 of their leading executives were actually fined more than $600 million, which wasn't a drop in the bucket, but at their gross product receivables for that year was $2.8 billion. It didn't bankrupt them. Now they're under intense scrutiny, obviously. The Purdue Pharma, or Purdue Company now, is being sued by many, many states and municipalities, including the city of Chicago, which actually has instituted a lawsuit 2 years ago against the manufacturers for misbranding. And the people in the Sackler family, which were the brain childs of this entire process of Purdue Pharma, are actually on the run. They're almost being kicked out of New York. They created one of the wings at the Guggenheim Museum, and they're under intense scrutiny. Then we had the CDC guidelines, which were basically created for primary care physicians, but more recently were adopted for pain management physicians as well. Here's a Purdue Pharma headquarters up in Bristol, Connecticut. The Joint Commission really tries to deny any culpability, but they wrote this primer. They cannot deny that this primer is still in existence and floating around, was distributed to primary care offices throughout the entire country, and the Joint Commission stated this, that we ought to be using opioids for chronic, not just malignant, but chronic non-malignant pain, because there's an attitude of exaggeration and inaccuracy amongst physicians in terms of the risks of addiction. Joint Commission, we all know who they are, and they obviously trying to exclude themselves from any culpability whatsoever. Further, we know about the statistics, and I'm going to go through a series of statistics. The most recent iteration of statistics from the Center for Disease Control and Prevention. You know that the Americans constitute about 4.4% of the world's population, right? We have 325 million Americans, and that's of a world population of 7.2 billion. We'll talk about that in just a minute. We consume somewhere, and the statistics vary from year to year and from chemical to chemical, but we consume anywhere from 70 to 75% of all the world's opioids. And that's a unique feature of being American, I guess. We have the several deaths. The statistics vary between 88 persons dying per day from opioid overdoses to now the most recent statistics suggest that there's about 130 people dying per day from overdoses, 130 people dying per day. And in a 15-year period, there were 165,000 deaths due to opioids. So this is from the journal Pain Physician. And if you look over a 15-year period, look at the hydrocodone statistics. Americans consume almost every molecule of hydrocodone in the entire world every year, each and every year for the last 15 years. Oxycodone, a little bit less. But in aggregate, we're consuming somewhere between 68% of all the opioids up to about 75% of all the opioids across the globe. Well, actually, the CDC in 2018 admitted that they had made a mistake. I'm going to talk to you about that, but keep that in mind. Really, what we have to be concerned about in many regards is illicit fentanyl and the derivatives that are streaming across our borders through Canada and through Mexico, largely created in China. And here you can see Customs and Border Patrol officers posing next to 650 pounds of seized fentanyl and methamphetamine. This is a recent picture from January 2019. James McDonald, who is the Assistant Secretary for Countering Weapons of Mass Destruction, has actually classified, as of this year, February of this year, February 22nd, has classified fentanyl as a weapon of mass destruction. Now, is that true? Or is that not true? Those of you who are old enough remember this siege that occurred about 17 years ago in Moscow. There was an auditorium in Moscow filled with 900 patrons attending a show. And there were about 40 terrorists from the Special Purpose Islamic Regiment who stormed it, and they were wearing gas masks, and they were making certain demands about the Russian government releasing certain Chechen rebels who had been held captives in prisons in Moscow and throughout the Russian Empire. And what they did was the Russian government didn't know what to do. They had this incredible hostage situation, so they went to their Spetsnaz, which is their super secret organization, somewhat like a hybrid between our CIA and our FBI. And they said, how do we avert this hostage situation and free the hostages? So they contacted, through our FBI here in the United States, Theodore Stanley. Ted Stanley, a good friend of mine, deceased now for the past 2 years, was working at the University of Utah Laboratories. Actually, Dr. Stanley was called Dr. Fentanyl because he actually created many of the fentanyl products and byproducts which are in use experimentally. Low fentanyl, carfentanil. He also helped to create remifentanil and sufentanil, amongst other chemicals, with Janssen Pharmaceuticals. And Stanley said, the way you're going to get these hostages freed is to put fentanyl in the ventilation system. And of course, when he went back to the Russians, or the Spetsnaz, he told them to use very, very small aliquots of fentanyl. But the Russians, being stubborn, apparently put in 10 or 15 or 100 times the concentration and dose of fentanyl, and it ended up killing more than 130 of these hostages during this crisis due to respiratory embarrassment. They had very pleasant sleep, fell off to sleep, and by the time the Spetsnaz was able to storm the building, they had lost 130 of the hostages as well as all 40 of the terrorists. And that was Ted Stanley. So we know that not only are narcotics increasing exponentially over time, also amphetamines are increasing. The prescription writing for amphetamines is increasing more than the prescription writing for narcotics in this country. This is the latest and greatest statistics of national drug overdose deaths. We've got 70,000 drug overdoses per year as of 2017 in this country. That's like filling up the entire Soldier Field where the Chicago Bears play and killing every single person, and doing that once per year. That's how many people die of drug overdoses in this country. However, and the good news is that physicians are getting the message. We are now seeing proportionally less individuals dying from prescription opioid writing than from the use of synthetic narcotics. So people continue to die. There are about 17,000 or so deaths, 28,000 from synthetic narcotics, and about 17,000 from prescriptions. But as you can see from each one of these following slides, the number of deaths is increasing with synthetic narcotics, as I previously mentioned to you. National drug overdose deaths involving any opioids is about 47,600 as per 2017. But prescription opioids and other synthetic narcotics is on the rise. Actually, prescription opioids without synthetic drugs, without the fentanyl and the other adulterations, is actually going down. So physicians are not doing a bad job. We're doing a reasonably good job of listening to the message. We are actually killing less people than we have been in the past. How about heroin? Heroin deaths are on the rise, but heroin with other synthetic narcotics continues to rise at the most rapid rate compared to the use of heroin alone. Cocaine and other synthetic narcotics. All these people are mixing and matching, and the individuals who are on polypharmaceutical self-prescribed drug regimens continues exponentially to increase. Benzodiazepines and other synthetic narcotics. Benzodiazepine deaths alone are not on the rise, but benzodiazepines with other synthetic narcotics. And so this was very interesting because I've rarely, if ever, seen the Center for Disease Control ever admit that they made a mistake. And in 2018, they realized that their statistics were inflated. Well, the horse was already out of the barn, right? The water was already under the bridge. They had already told us that physicians were killing patients, but they neglected until last year to admit that the rapid rise, the accelerated rise, the exponential rise in deaths was not due to those of us in this audience or our colleagues. It was really due to the fact that synthetic narcotics were what was killing individuals at this accelerated rate. So what do? How have we gotten here? We have had a pendulum swing. Several years ago in California, physicians were being arrested and losing their medical license for under-prescribing narcotics. And there's case law, which was sensationalized. How did that happen? Well, there were family members and individual patients who claimed that their pain was unmitigated, that their pain was undertreated, that their pain was not sufficiently modulated using narcotics. And we all know what that message was. Give the patient what they need. Pain is a vital sign. Pain is whatever the patient says it is. You've got to treat the pain. And now the pendulum is swinging back from indiscriminate use back towards avoidance. Let's go back to these statistics because you need to read this article out of Pain Physician a couple of years ago. It's fantastic. But look at the number of deaths, not deaths, look at the percentage of Americans consuming narcotics or the percentage of narcotics being consumed by Americans. It's actually astronomical. Anywhere from about 68% to 75%. What is unique about the American individual that makes us demand narcotics at such a rate? We have a sense of entitlement, ladies and gentlemen. Our patients do not want to feel any discomfort or any pain. And that's promulgated in the lay press. We talk about the right way and the wrong way to treat pain. God help you if your doctor doesn't know the right way to treat pain. And we talk about pain in militaristic terms. We talk about conquering pain, beating pain. We've declared a war on pain. And then, of course, now we want to understand pain as this pendulum swings back towards being less aggressive with the use of medications. We've also become the United States of America Juana, right? Everyone wants to use marijuana. Just this last week or 2 weeks ago, the state of Illinois legalized the use of recreational marijuana, and it's coming to us, to a theater near you. And then, of course, we also want to know about addiction. But Americans don't want to do the work to cure addiction. They want a vaccine. Americans are looking for a vaccine so they can continue to use their disproportional amount of narcotics without having to have the consequences and having to deal with this by looking at their personalities and the stressors in their lives and doing the work to get unaddicted. And then, of course, we sensationalize all the characters in our experience, in our world who have become addicted, and we make heroes out of these individuals. Michael Jackson, a big hero, the king of pain, who was using Vicodin, Dilaudid, Xanax, Zoloft, Demerol, Prilosec, Paxil, all these drugs on a regular, ongoing basis for 25 years. We sensationalize Whitney Houston, and we sensationalize Prince. This is the last picture of Prince ever taken when he went to his Walgreens pharmacy after having passed out on his private jet airplane coming back from a venue and picking up his last 320 tablets of oxycodone one day before he actually died. So what about the casualties of ourselves, of our physicians? They exist. We've all been swept up in this massive opioid epidemic. Here's Tesher Martin. Actually, Martin Tesher, this was backwards from the New York Post. 83-year-old physician in New York City who wrote 2.2 million tablets of oxycodone over a 10-year period, including killing a 26-year-old Staten Island man. He's getting 20 years in a federal prison. So he's one of the consequences of this, being swept up and trying to be beneficial and being benevolent to his patients, perhaps. How about Todd Graham over in Indianapolis, just a few miles away from here, killed a year and a half or so ago. He was killed because he did all the right things. He met a new patient. The patient came into his office, to his pain clinic, requesting narcotics, she and her husband. And he said, I don't give narcotics to new patients on the first visit. And the husband was irate. He said, of course you have to give her. She's going to have withdrawal. And Todd Graham said, she's going to have to go back to her primary care physician to get her oxycodone. And the patient and the patient's husband went out into the parking lot, waited for Dr. Todd Graham to come out after work. The husband approached Todd Graham and shot him twice in the head. And this is not an isolated case, ladies and gentlemen. This is one of the physician casualties of the opioid epidemic. So what's the future? We have a duty, and we have to identify high-risk patients by performing comprehensive evaluations. We have to diagnose and document our physical examination pertinent findings. We have to stratify the risks to our patients and to ourselves, create treatment goals, and avoid long-acting opioid use at initiation. We have to educate our patients regarding adverse events, and we have to use high-dose or long-acting opioids only in the case of intractable pain while monitoring for side effects. This is a great paper published 2 years ago in Pain Physician, and the citation is on top. I encourage all of you to avail yourself of this. Dr. Manchicanti pointed out, this is available online, gratis, free of charge, and you should all be very much familiar with what the peer-reviewed literature states in regards to the responsible, safe, and effective prescription of opioids for non-cancer pain. You should know what the levels of evidence are and how that juxtaposes to you in your own personal practice. So level 1 evidence is the highest level of evidence. Comprehensive assessment and documentation, establishing appropriate physical diagnosis and psychological diagnoses where applicable, stratifying patients, establishing treatment goals on opioid therapy. Remember, patients don't present to you with the scarlet letter of A for addiction when they come to you, right? What are the high-risk patients? Well, below the age of 45 years old, males with a family history of prescription or alcohol drug abuse, cigarette smokers. These are the highest risk patients, and there are both biological as well as psychiatric and social implications on individuals who present to you for treatment. Stratify your patients, low risk, medium risk, or moderate risk, and high risk patients. Obviously the highest risk patients are those which is intuitive and inferential. They're actively abusing substances, they've had a history of untreated addiction, they've got major untreated psychological disorders, and they're at significant risk to themselves or the practitioner. Other level 1 evidence, avoid long-acting opioids for the initiation of therapy. Recommend methadone. Very rarely, methadone should not be used in the vast majority of individuals with chronic non-malignant pain. Understand and educate your patients on the effectiveness of medications as well as the adverse events attendant to their use. Recommend long-acting or high-dose opioids only in very select specific circumstances. And monitor for side effects, including the 6 known side effects attendant to the use of opioids: nausea, vomiting, itching, urinary retention, constipation, and respiratory depression. And we've seen these statistics. Really, it's the synthetic drugs which are really on the astronomical rise. We've talked about this at length. Now, Prime Minister Trudeau is very happy with the great strides his country has made with socialized medicine and so forth, and here he is with our President Trump. But if you look at Canada, they're not doing so well either. The international use of 6 powerful opioids, Canada is actually beating the United States of America. So the Canadians are not doing a great job of monitoring the distribution, the sale, and the consumption of opioids. And so Trudeau has something else to be proud of about beating the United States. They are consuming more narcotics now than the United States of these 6 powerful narcotics. So conclusions. Through 2019, drug overdose remains a large and growing public health crisis, but prescription opioids are not the focus. They're not the onus upon which the opioid epidemic has its foundation or basis. These were formerly driving the crisis. Now it's the fentanyls, the cocaines, the heroines, and the methamphetamines which have taken the lead. Leveling off in the decline in opioid prescriptions since 2012 signals that we get it. We understand that we have a duty to our patients to first do no harm. Primum non nocere. First, do no harm to our patients. And now we have urgent measures are needed to address the diverse and growing list of drug classes and types. I thank you for your time and attention. And I think we have a break now. And I just want to, before we break, I want to introduce my Director of Clinical Research who will be speaking to you later tomorrow. Dr. Nick Nesbitt, she's got a message to you about a research opportunity. Very briefly, for 2 seconds.
Well, we're just doing one simple survey for collaboration with the Candido mentioned primary care physicians and pain physicians. We'll need your input if you are willing. We kept 2-hour research assistants going around to complete the 3-minute survey. We'll appreciate it. Thank you, sir.
Thank you.
There is a small announcement. We are running behind, so we want to take a 15 minutes